One of the exciting things in many of these meetings, especially here at the ECR, is you get to see scientific sessions. Scientific sessions are things that are telling us about what is coming, the research that is being done. And one of the exciting things in artificial intelligence, which is my area of expertise that we're starting to see, is that we can do things on the back end to make the patient experience better. So what do I mean by that? When you think about how artificial intelligence can be applied, what we talk about is the life cycle of imaging. And it starts at, I'll say, the top, where a physician has a clinical question from a patient and they need to figure out the answer and they need to order a study. All of the acquisition, the scheduling, the reconstruction, all of that part is super important. And I think that tends to get lost a little bit. A lot of people in artificial intelligence are thinking about the other side, which is the interpretation. So I think it's very exciting to think about what we can do on the back end. And in artificial intelligence, with the imaging acquisition, what we're starting to see is the ability to decrease the amount of contrast that we can give, especially gadolinium contrast for MR imaging. We can decrease the dosage and upregulate that, sort of extend the ability of that contrast using artificial intelligence. It's really exciting because contrast is something a little different than we usually look at with AI. So with AI, if you might upregulate something, we're upregulating something that is morphological, something that you can see that is visual. Once you start looking at contrast, that's biological. We're talking about physiologic properties. So the AI has to mimic that physiologic property of how contrast gets ingested, the permeability of the vessels, where it is going. And that to me is quite exciting. We always want to be able to have the patient on the scanner for less time. We want to give them less injections, especially for people that are coming again and again to get repeated imaging with contrast. We have the ability now to start reducing that dose. And the question is, how low can we go? I think every radiologist should actively get involved with using AI. It's wonderful to come to these meetings because part of what you do at these meetings, aside from seeing all of the research, you can see clinical implementations. You can talk to people who are actually using these tools and then try to get access and use them yourselves. Dive in. That's the absolute best way to learn. I will tell you, I never took a course on AI. I developed my own expertise by using these tools, validating them, thinking about what's the safest way to use them. How do we educate other people about it? The other recommendation I would say is to talk with vendors. Vendors are fantastic sources of information. They can provide all kinds of science behind what they're doing. They're running clinical studies. They can tell you what's actually occurring in those studies. So go out and talk with different vendors, meet the different people, network, and get involved. There's a really interesting new sort of versions of technology that have been evolving just in artificial intelligence in general. And what's exciting is in medicine, for one of the very first times, we tend to be late adopters, but with AI, especially in radiology, we're early adopters. And what we're seeing is these foundation models that are out there, like the ChatGPTs and Claudes and Geminis of the world, they are coming into radiology very specifically. Where we are seeing them move is we're moving from these narrow AI solutions that looked for a single thing. They would classify a single finding as present or absent. And while that is interesting and it's useful to improve our ability to detect findings, it doesn't really help our capacity. We need something more general. And these more general models are now becoming more and more available. We're seeing language-only models for radiology that assist with reporting. And even more exciting are vision language models. Now, vision language models are multimodal foundation models. Multimodal because they have both vision and language. And that means they are looking at the images, and they're also ingesting radiology reports. They learn from a vast amount of information. And then when you provide new imaging to them, they could create a radiology report almost like an AI resident. Now, how is this different from the narrow AI? Multiple ways. Number one, it's not looking for just a single finding. It's looking for anything. When you ask a ChatGPT or a Gemini a question, it was not trained specifically on that question. It is a general model. So these new vision language models in radiology are general. Number two, it is providing information about the entire study. And number three, it is providing descriptors of the findings. So when we dictate as radiologists, we don't just say there's a lung nodule, yes or no. We say there's a lung nodule, it's in the right upper lobe, it measures this, it looks increased in size from prior, here's the associated findings. These are what general vision language models can do, and we're starting to see them come into radiology. I will mention that language models, you could probably use a language model that is a open source or one that is being used for non-medical findings. You could probably use them for medicine, especially with a little bit of fine tuning. That is not true with vision language models. You do not want to take a Grok or a ChatGPT and just run your own images through that. You need a radiology specific vision language model. We're starting to see these come out in research. We're using them in my practice right now, and we're seeing significant improvements in terms of both quality and capacity, along with radiologist burnout. One of the things that I like to think about in order to understand where we're going with artificial intelligence is to think about frameworks. Frameworks help me put a scaffolding behind the information that I get. And there's a very useful framework that I've recently been sharing that people have found quite useful. So it's a two-dimensional framework. So you have a x-axis and you have a y-axis, and we're talking about the maturity of AI. And a maturity of AI has to go in both directions. I think so far we've mostly been thinking about one direction, and that's the model itself, which we've talked about a little bit. You could have a single narrow AI model that is a classification model. That's a lot of what we're seeing in radiology today. You could go up to the next level and see multiple different AI narrow models. It's trying to find multiple findings, but it is simply a classification with multiple things. Most of what we're seeing all across the world in artificial intelligence and radiology is at that level. You go above that to the next level, and we're starting to see foundation models, which we were talking about before. These are large language models. This is a unimodal AI, just one thing. And we are starting to use them in radiology reporting. The next level is vision language models. We talked about that. Those are going to transform how we practice radiology. It is like someone drafting a report for you, so you don't have to do that initial work. You elevate your role as a radiologist. And then will be other kinds of multimodal AI. So that is one part of the framework that I think a lot of people are thinking about. But what I want to point out is the other side of the framework, and that's the system level. The system level is, how do these tools start working together? And the way that I think about it is kind of like a orchestra. Where we're here in Vienna, we should be talking about music and orchestra. If you have an orchestra, it's made up of lots of different instruments. Those are all individual tools. It may be an AI tool or a data source. Maybe it's a foundation model. Maybe it's a narrow AI tool. But what happens when those tools are working together? You get this outsized impact. And that's what I'm talking about on the system level. How do these tools orchestrate and work together and affect the system that we're working in so it feels seamless? That's when we're going to start to get the impact of the 1 + 1 = 3. And not the sort of linear improvement that we're finding today. Outsized impact is what we need in order to manage the massive volume capacity mismatch that we have in radiology, both at the physician level and also at the level of our technologists. So think about it in both ways. I think that we're maturing now on both sides. We're starting to move up toward foundation models, and we're starting to move over from tools to workflow to orchestration, and then where we're going next, agentic AI.